everyone, my name is Timothy Harris, and today I'm here at UCSF with Dr. Eric Goosby. Dr. Eric Goosby is a global AIDS coordinator associated with several developments in AIDS research. He has been an advisor for Biden and Obama. So who are you and what do you do?
Well, thanks. It's a real pleasure to have an opportunity to talk to you today. I'm a professor of medicine at the University of California, San Francisco School of Medicine. And in addition to teaching medical students and fellows about basic disease and pathophysiology, some traditional didactic lectures, I mostly teach clinical activity for the fellows in the wards, in the medical wards at San Francisco General Hospital. And there are third and fourth year students who rotate through those inpatient services. So I see kind of the medical school students as well as interns, residents, and fellows. That is the medical school part of my job. And then the other part of the job is looking at what are the elements in a Ministry of Health in their ability to stand up, manage, and oversee programs that diagnose and treat HIV, TB. And I will go to those countries and work with ministries of health to start clinics, to get labs that support those clinics in diagnostic tests that are needed, stand up pharmacies that supply the unique antiviral drugs that HIV and for antimycobacterial drugs for TB. They're needed. There are many drugs that you give, 3 drugs for HIV and 6 drugs for TB. And for a doctor or for a nurse caring for that patient, it's a real juggle to make sure the side effects don't dominate and they complete the medication to get the cure for TB and to stop progression for HIV. So I do clinical and research. The research is implementation research. It's focused on understanding, defining what are the critical elements that are needed for a Ministry of Health to successfully stand up a program that diagnoses and treats one of these life-threatening diseases.
So it seems like you're more so on the epidemiology side than the actual research side. Is it a mixture of both, or is it one or the other?
It's more of an epi side of the equation, but in all of the settings we're in, we do clinical trials for new drugs that are used for HIV and for TB. So it's not understanding the pathophysiology of the virus. It's really looking at targets that we already have identified in past research from years ago that we can use to develop a drug that will stop the virus from replicating for HIV. For TB, the mycobacterium, it's a little different organism, but the same idea. And in order to effectively treat both HIV and TB, you need to keep the person on these drugs for very long periods of time. For HIV, it's for their whole life. The drugs only work when the virus divides, so it's got to be around for viral division. And the same for TB. The anti-TB drugs only work at the moment the mycobacterium divides. And it divides very slowly, every 6 weeks. The viruses divide in hours. Mycobacterium divides glacially. So you have to keep the drugs on for 6 months, a year. For more difficult to treat forms of TB, 2 to 3 years. So it's a real mystery in any given individual. So you need a delivery system that can stay with the patient to understand how they're reacting to the drugs once you've diagnosed them with TB or HIV and start them on treatment. There are bad paths that they could go, and you need to be in close contact with them as you get them on therapy that works.
This is a good point, because one of the things that my microbial biology teacher said is it's hard for a patient that's homeless with tuberculosis to actually get treated for tuberculosis. Do you have any insight on that, especially with the San Francisco area having a significant homeless population?
Yeah, have a lot to do. When there is a person who has tuberculosis, I usually end up seeing them. And because there just aren't that many people with TB in the city. But it's very true for any disease, but especially chronic progressive diseases like HIV, TB, where you need treatment for long periods of time. That's complicated, involves more than one drug. So if you don't have a home to be in, to take your medicines in, to store your medicines, to rest and recoup, you are a patient that is very difficult to keep on medication. So homelessness is a corruptor for any disease, but HIV and TB especially. But it runs havoc on diabetes and hypertension as well.
What struggles did you go through trying to coordinate the COVID-19 response with President Joe Biden?
Well, the difficulty in a response to a new threat. So COVID had not been present in the world before 2019. We did not know how it infected, except we knew viruses that were similar to it. We'd studied them and we knew how they infected. So we had guidelines to approach the virus. But people don't realize that virus didn't exist in 2018. And in 2019, two virus particles got together and suddenly began to be able to attach themselves, which they hadn't before, to a human cell. And that new ability allowed them to infect those cells and go into a whole population that they had not entered. With that, a new threat, you have delivery systems that are set up for the threats you know about, but are not set up for the threats you don't know about, and are not often easily, manipulated to accommodate the new demands that the new threat presents. Our ability to identify who in the population is susceptible to infection. In the population, are there people with comorbidities or other problems, diseases, states that predispose them to a worse clinical course than those without it? So high-risk groups. We found in COVID that obesity, hypertension, diabetes, history of malignancy, lupus, collagen vascular diseases, or TB or HIV strongly predisposed you to being more susceptible to attachment and infection. So those populations became the first people we started to see in emergency rooms. The other group was people over 65 and obesity. Those were the big comorbidities that targeted individuals for more easy access from the virus and infection, and moving those people into the advanced stages of the disease. About 20% of those people who got infected needed to be admitted to the hospital. And of those, over 3/4 of them were over 65 years old. And of those, half of those people who were admitted to the hospital over 65 had one of those comorbidities that we talked about: hypertension, diabetes, obesity, or a malignancy, collagen vascular disease, something that affected their immune function. So all of that needed to be figured out on day one as best you could, because you don't have the luxury of saying, hold up, wait a minute, come back when we figured this out a little bit. They're already in the emergency room, they're already short of breath, they're deteriorating, and as with any disease, doctors have to respond to that. So you respond symptomatically, correcting numbers, trying to make them look like a normal human being in terms of oxygen, sodium, potassium, chloride, all the electrolytes. But that isn't treating the underlying problem. And we had to de novo develop new drugs that allowed, first diagnostics that allowed us to diagnose COVID, because we couldn't tell you if you were sick from COVID or something else until we did. So a diagnostic test that confirms the infection. And then once confirmed, that we developed new drugs that target unique aspects about the metabolism of COVID that your normal cells, human cells, don't have, to allow us to give poison for the bug, but not for the human. So the magic bullet idea with an anti-COVID drug. We did successfully find those drugs, and in record time. The development of the vaccine was also in record time, and there's a whole story to go along with that. But it combined the knowledge from epidemiologists and clinicians in the first few weeks of COVID on the planet to come up with a response and a protocol to respond. The confusion around contact on surfaces or respiratory spread was because we hadn't looked at it to figure out which way it predominantly moved from one human to another. You can't just intuit that, you have to observe it, measure it, and then confirm it. And all of that takes about 6 weeks to do if you do it as rapidly as you can. So I would tell you that the lightning speed in which diagnostics were identified, a vaccine was identified, and effective therapeutics is breathtaking and speaks to the coordination and communication that already existed in the physician scientist cohort that responded and developed that first response. They were all deeply immersed in viral movement on the planet with HIV and had developed, stood up systems de novo 20 years ago, 25 years ago for HIV that was the same situation where a new threat had to be accommodated in an existing delivery system. Mm-hmm. So,
describe to me your childhood and how you found yourself working in AIDS specifically.
I was born in San Francisco, grew up here, and went through school here. I knew medicine was important to me from growing up, liked it, gravitated to it. Science was always of interest to me early on, but I thought I was going to be a marine biologist, something like that. I wasn't thinking medicine until I was a freshman in college, where I did volunteer work as a big brother. It's a program, federal program that's very old now, but you as an undergraduate do tutoring once a week with a student who's usually without a parent or in a child facility that they used to call orphanages, but now they're a little more sophisticated. But and I had a young boy who got a headache and a fever, and through the course of our study session, which was just a couple hours, in Trenton, New Jersey, he went from sitting there talking to me, working on a problem, to unconscious, unresponsive. And we took him to the emergency room, and he turned out to have bacterial meningitis. They did a lumbar puncture on him. I was an undergraduate, right? I didn't have any medical background. And pus came out of his spinal cord. Frank pus, like out of an abscess. And they gave him antibiotics there in the emergency room, and this kid was as close to death as you're going to get, but through the course of about 3 days went from comatose to sitting up there wanting to play in the bed. So got the right antibiotics at the right time. Had he not, he would have almost certainly died. And at that moment, I realized, forget the marine biology. What I want to do is with humans, and this is it, and really focused on that at that point, and never really looked away from it. Knew then that was going to make me happy, was the intellectual stimulation I wanted, matched with the science. It combines all the pieces that are applicable to the human body in science from the other disciplines. They take those, and that's what you study in medicine. It's all the little pieces that apply to human beings from every other field, in the biology, chemistry, biochemistry, physics, all of that. And I saw that as an undergraduate and saw it as a unifying kind of field of study. My interest was stimulated then, and I basically went straight through undergrad, majored in biochemistry, and then went to medical school. Straight on through, didn't kind of take a holiday somewhere, went right through it. Right decision for me. I've enjoyed all of it. It is the combination I thought it was, and it gives you, being a physician, a skill set that allows you to do almost anything in terms of a job or change a job, a new profession as you move through your career. An MD degree is very versatile, kind of like a JD degree, even more so in some ways though. And it gives you great flexibility for movement. You can go anywhere in the world and work, and I've done that. And because of the shortages you were referring to when we first sat down in the African American community, minority community in general, there aren't enough physicians, or the physicians want to stay in cities and not go to rural settings, or want to work in rich neighborhoods in cities instead of poor neighborhoods. All of those gradients move physicians' talent away from Black communities, and they suffer for it. The other aspect is there's a deep distrust in Black communities that is really coast to coast, even though most communities never experienced a Tuskegee type event where research was done and abused them as members of that research cohort, but they do. And I think that hesitation to engage in services plays out in our community more than any other. And I think it's combined with the stain of slavery that put our people in a position where for hundreds of years they had to endure physical complaints and never reach a threshold of going to a doctor because it wasn't available to them and or they couldn't pay for it. And that is still the case today. We have a maldistribution of health providers, but we also have a maldistribution of health delivery systems available to people. The darker their skin is, the less available it is. And that gradient is in every state in our country.
So one of the things that I was, when I was studying at MCAT, there was something, it's called social stigma. And this social stigma that you put on somebody of discrimination leads to that person to achieve an internal self-stigma about themselves. Mm-hmm. And I like the analogy, or what you said here about there not being enough Black physicians or not being enough Black trust within a Black community to get healthcare. Mm-hmm. So what are ways we can start now and start reversing these issues besides research? What are some action or what are some next step things we can take within the next 5 years to really pan that out?
I think be honest about the rift, own it. The Tuskegee type activity, although extremely rare, it happened a couple of times in the history of the United States. It did happen. That was a situation where Black men in the late 50s, but mostly in the 60s, were diagnosed with syphilis involving their nervous system. And instead of getting penicillin, which would have cured it, 100%, 90%, 95%, a course of penicillin would cure it, they were not given penicillin and allowed to follow what happened to them in terms of physical exam, changes in the central nervous system from the syphilis advancing unchecked, and wrote about the natural history of syphilis by sacrificing these elderly Black men who were in a nursing home. Compos mentis completely. They weren't demented or a problem. They just were chosen to do this. Unconscionable, unethical. A lot was made out of that. It'll kind of never happen again in a awake, alert society. But it has to be awake and alert to not let it happen again. And I think that being honest about the insult that represented and the failure of the medical delivery system and the medical profession to police it and stop it from happening, and then once identified, to not own it as a problem such as it was, created more distrust. And Black people in our society are given at every turn the message that they're different, that authority will react differently to them when seen. And we see that in any aspect of society you want to throw out there, from policing to education to healthcare. And we know that affects the self-perception of an African American deeply, but we never talk about it. And what I mean by that is it's a two-way street. African Americans have the opportunity to get health care if they demand it. But they don't perceive themselves on some level as worthy of getting that kind of health care, of deserving that kind of health care, because they stay silent and don't engage for themselves, for their parents, for their children. That is a deeply rooted self-hate that is fostered and manifest in the inaction when there is I've got chest pain, I'm short of breath, I can't lie flat in bed because I wake up short of breath. I've had patients that have had that complaint for 3 years and live a half a block away from the emergency room, but have never engaged with it. These can be college-educated Black people. Okay, there's a message there that is in our consciousness that is telling us, endure, don't engage. You can't afford it, you don't deserve it, you won't get it. Any reason at all for not engaging. But the decision is made not to engage. It's not go to the place and get turned away or get treated poorly, it's don't engage. And we've got to own that as a community, as a people. And the delivery system that responds to this has to understand that and directly engage it. That self-perception deficit.
So I want to take a turn here in the conversation. Okay. I appreciate that insight. Yeah, okay. I've never had a direct interviewer. Yeah. So what's your hot take?
My take on
something that you have a strong opinion on that's controversial.
Well, hot take. I like that how you term it. The hot take for me is along these lines. It's a deep awareness of the profession, and I'm talking about the medical profession in general, physicians specifically, not allowing in our delivery of healthcare to have disparities in how we diagnose or what we treat with for any given patient because they can't pay for it. Our system and our professionals in that system allow that to go on without calling foul. It's unconscionable. The physicians, the nurses, the health professionals who have studied and learned this science to diagnose and treat something should be appalled that they can't diagnose and treat something because the system wants money for that and will deny it to the person who needs it and would benefit from it just because they can't pay. And that's okay with us. And you're 31 when you finish your education if you did it right on time, straight through, didn't take a day off when you start to practice medicine. That's as just an internist. Then you can do 2 more years to subspecialize in cardiology, infectious diseases, gastroenterology or whatever. And even that individual who's dedicated and sacrificed to do all of that doesn't get indignant when they're told they can't pay for it. You can't use that drug. You can't give them that treatment. Happens every day, many times a day, and we have numbed the profession up so they think that's appropriate. The disparities in outcomes, who benefits from the science that we already know, is reflected in socioeconomics and racial, goes down socioeconomics and racial lines. The darker you are, the poorer you are, the less likely you are to get in front of, again, the science we already know. And the system is less likely, the darker you are, to keep track of you. So they know they didn't get you. Okay, they've got it all the system really doesn't remind itself of transgressions.
So what makes you, do you know who Dr. Monica Gandhi is?
I know her very well.
You know her very well.
Yeah.
So one thing I like about her, and I'm actually going to interview her later on, and so it's going to be fun bringing you up to her.
Yeah.
I like how
I love Monica Gandhi.
I like how outspoken she is on the news, on the news, and so I think that's one thing that both of you guys have in common. What gives you that courage or that drive, that determination to really speak out against these controversial topics?
Gee, I never thought of it that way. You're compelled to do it or you're not. And I was raised this way. my parents you'd recognize the energy. Okay, I was raised in a household that saw problems and engaged them and thought less of you if you didn't. Okay, so it was, that expectation was present. Most aren't raised with that, so they don't have that kind of energy there. But I would say the intellectual honesty of it is why it flows out for me. It's because it's the truth. I'm in front of it. Most aren't. I see it in the United States. I see it in San Francisco. I see it in poor areas in the United States. But it's all over the globe in the same reflection. It happens, that cascade of socioeconomics or racial discrimination cascades in every country. And it's the kind of denial of the medical profession to call foul with who gets care and who doesn't get care is also in every country. Mm-hmm. Even countries that have national health insurance have populations that access more easily or are retained, over time more carefully than other racial groups. Calling foul and saying, I don't think it's right that I can't treat this patient with what the guidelines, the science says I should, because they can't pay for it.
So there was a quote. I'm gonna take things to a different shift here.
Okay.
So there was a quote. It says, "You are 1 in 5 of every single person you hang around." How applicable has this been to your success in your career in general?
You're 1 in 5? What do you mean?
You're 1 in 5. You are 1 in 5 of every single person that you hang around.
What does that mean?
That means every person that you hang around, the people within your close circle, they have a strong influence on you so much to where you're 20% of that person, 20% of that person, 20% of that person, and it all combines to make you. What do you think of that?
I think as you develop your personality, definitely. Once you've developed your personality, I don't think that it's that important, although influential for sure. Peer pressure until you're dead, it has an impact. Media and advertising is effective on human beings. That's why they do it so much. It took forever public health people to realize that and to use that in speaking to populations about risks and behavior change. But I do believe that it is influential, but as you get older and as you know more, you begin to be less influenced by someone else's opinion. And I think the aging process in a negative way even closes that down more. You're less open to someone else's opinion as you get older. And I feel that in myself. So I think that's a true thing. The fight is to remain open. You need to continue to be humble about what you know, but really clearer about what you don't know in medicine. And you're trained to think that way. And not overextend a decision. Be clear about where your decision is based on evidence and science knowledge, and when you're departing from that. That's what scientists need to be really clear about, is where the science starts and where it ends. And therefore what's needed for new investigation, new questions, new inquiries. And hopefully they're informed, if not defined, by the needs of the population as to what you do your science on. To do your science on irrelevant, low probability diseases that don't affect humans, so diseases that don't affect humans, has high utility in the science, natural history end of it. As a biologist, I'm really interested in what the woodpeckers, mating habits are like. But I'm more interested in why maternal and neonatal mortality in Oakland is so high. Approaches where it is in sub-Saharan Africa, where there's no doctor, no nurse, no midwife. Why is that? And it gets back into an explanation that includes self-expectation is in there. And we as a people, as Black people, need to get much better in touch with that to heal ourselves, because others aren't going to do it.
So Dr. Goosby, what's your guilty pleasure?
My guilty pleasure?
Yes.
I don't really have anything I feel guilty about. I mean, it's the truth. In terms of things that I do for recreation or pleasure, if that's kind of the line you're going on, I don't carry much guilt. That's the truth, yeah. Really, in any aspect of my life. I don't know. I think it's more how my parents raised me, and but don't pick up stuff you're going to feel guilty about, is kind of the theme. Sometimes you have to pick up stuff, but hopefully it's not stuff you're going to feel guilty about. But I think if you were in a military situation, you could come into dilemmas that could corrupt that safe space that I'm talking about. You know, where you got to kill them or they're going to kill you. I don't know how I'd react to that. You know what I mean? Those kind of things. But I don't. Yeah, it's an interesting question.
So within the next 5 to 10 years, what do you want to see realistically progressive for the Black community?
I would like to see the Black community benefit from the science we already know. All the evidence base that we've got on the shelf that informs guidelines for how to diagnose and treat hypertension, diabetes, coronary artery disease, understanding the role obesity plays in comorbidity development and potentiating other disease processes that would be less impactful had you not had hypertension and obesity on top of your diabetes. Getting a deeper understanding of that in the Black community is critical. The idea that you deserve to be diagnosed, you deserve to be treated, you deserve not to have those symptoms and not wake up short of breath every night, and demand the diagnosis and treatment that it requires. And that requires, first of all, that you show up. And I think our people have barriers at every stage of that engagement.
So for a STEM science, a minority STEM scientist, or wanting to be STEM scientists that comes from an underprivileged background, and they're not financially stable, they don't know if they can do it, but they have a high aspiration, they want to be an MD, Ph.D. What's your first step of advice for them to achieve that goal and to have that level of ambition?
It's all based in your school, your ability to perform. So that's got to be the number one priority. You need to be ruthless about putting together the ingredients to being an excellent student. Earlier you do it, the better. Be ruthless about it, demand it of your family and of your schools that you're in as you go through them. Don't think about it, I'll do it next year. Be in a dialogue with your kind of teachers and their kind of principal leadership about what you think is working and what isn't working as a community. I'm talking about not as an individual, but as a community. We need to do that work because others haven't done it for us. So you need to be the parent that is in the teacher's face, aware of what your kid is getting in homework, aware of how your kid is being reacted to by the teachers, and all of that. And if that isn't happening, we have to own part of the, that we need to own that too. It's not just the dominant culture ignoring us. It's that we aren't knocking at the door and demanding to be heard and seen. That can't stop. No one's going to give it to you without a fight. No one gives you anything without you kind of taking it away from them or them feeling like you are. And I'm not talking about violence. I'm talking about intellectual engagement around the disparities that have been documented for as long as I've been alive, but have not been acted on.
I see. Well, Dr. Goosby, I do appreciate you. Thank you for the interview. Like your insight. Thank you for everything.
You're welcome. Thank you.